Namaskar. Welcome to this 252nd episode of Fogsi Gyan Pravah, a brainchild of our president, Dr. Sunita Tandulwadkar, madam. As we all know, madam is the president and she has a biodata that spans multiple pages. Recently, she has been awarded the FICOG from Royal College. She has a prize from the President of India, and she is a pioneer in stem cell and regenerative health. So, madam, because she is busy in the FIGO program today, we have Dr. Ashwini Kale, our Joint Secretary, who's going to introduce the program. Welcome, Dr. Ashwini.
Thank you so much, madam. A warm welcome to Gitanjali, madam, also. So basically, this is the brainchild of Sunita, madam, where we have this Gyan Pravah podcast every day by one of the chairpersons from 8 to 9 p.m. sharp. And it goes on for 45 minutes. And there are 30 committee chairpersons of Fogsi who have been religiously doing it from the month of January. So I'm very glad we have completed over 250 episodes today. And not even a single day is generally missed by Sunita, madam, unless and until either she is out of India or in the flight. All the episodes have been chaired by her. So it is really a privilege to have you here. With Fogsi, we have been working very closely with our project, which is Sampurna, which is on preconception care. And now we have even made master trainers of this, and we are working across the country to create awareness about the importance of preconception care so that it automatically reduces the maternal mortality and morbidity. We also have multiple other programs going on, which is our Nirmal Banaras program, which is against cervical cancer elimination and also creating awareness about the HPV vaccine. And I must very proudly say that Asha madam herself have completed over 95 CMEs by GSK on maternal immunization across India. So that has also been one of the very huge programs that Fogsi has run. So we would definitely like to hear from you, and I think I'll log out and join in from the general link. And I think this is also very important for all of our Foxians because we do so much of work, but we hardly publish. Even this year, Fogsi has undertaken 7 different studies across India, which are on very simple topics like prevalence of anemia, prevalence of high-risk disorders, or even the prevalence of the use of contraception across couples across India. And we have come out with data which is to the tune of almost 1 lakh women. So we are now in the process of publishing it in various journals. And one of our journal that we are looking at is Jogi, which is our Foxy's own journal. So probably in the next 2 months' time, we'll come out with this study. So over to you, Asha madam, and wish you all the very best.
Thank you, Dr. Ashwini. Thank you.
Asha madam, you're muted. Huh?
Thank you, Dr. Ashwini. Today we are going to talk on research opportunities, and who better than, Women's Health Head, Dr. Gitanjali Sachdev from ICMR, National Institute of Reproductive and Child Health. She is with us today, and we are going to discuss basically how we are 46,000 gynecologists, and we can contribute a lot. So having madam here, I would like her to tell us how we as gynecologists, those who are in the government setup get involved in something or the other, but those who are in the private setup, and a majority of our members are in the private setup. So how they can also get involved in research and produce quality and quantity. So thank you so much, Gitanjali ma'am. I'm going to enjoy talking to you. I hope you enjoy as well.
I would. Okay.
So, ma'am, you are looking after research for so many years. In the last 5 years, if there was one thing that you could change in women's research, what would that be?
First of all, I would like to thank you for inviting me here. And I would also like to thank Fogsi for inviting me to be a part of this conversation on women's health. I think it's a global phenomenon now. Everyone is having interest in women's health research, especially because so far we have been just equating women's health with reproductive and maternal health. So now we are shifting gears to other areas which demand attention when it comes to women's health. Now, coming back to what you were asking me, what I would change, I would say rather than changing, I would like to say that more should be done besides whatever is being done in the area of women's health. I know anemia, cancer, they have received a lot of attention, and so due attention, I would say. But I would say besides anemia, cancer, there are more areas which need our attention in terms of research and also in terms of action. So
You are at a premier place.
yeah,
What are the research gaps?
yeah.
Where is research needed?
Yeah, that's what I'm going to tell you about this. I'm sure you must have you must have heard about this NFHS 5 data, which clearly indicate that more women are getting affected by NCDs. More than 50% of women, they have one chronic condition, and more than 25%, they have more than one chronic conditions or more than two chronic conditions. So multimorbidity can be an area of interest. Besides that, autoimmunity, mood, anxiety disorders, bone health. These are the areas which need more research, and I would like to see more research is done in these areas which are probably not women specific, but they need attention. Besides that, I think endometriosis, adenomyosis, vaginal health, these are very important areas which need more research. So I would like to see more research being done in these areas. And as you know, we cannot do research without funding. So I would like to see more funding is allocated to these areas which are under research.
So what are the areas which can be funded right now?
I think all these areas have potential to be researched more, so more funding, especially menopause. Now we know that Indian women, they have menopause much earlier than their Western counterparts. So they are at risk of osteoporosis, cardiovascular health, and also mental health. So menopause should, the area of menopause should be funded, and it needs more research, more interventions to screen and prevent all those morbidities which are associated with the menopause.
Ma'am, after COVID, we are seeing a lot of premature menopause or low ovarian reserve. That has happened after COVID. And, we have in India, we say the average age of menopause is less, but we find that we have both extremes. We have somebody who has become menopausal in less than 40, and we also have women of 55 and 56 regularly menstruating.
I know, yeah, these are also the areas which need why after pandemic, more women are getting premature menopause or let's say early menopause, like after 40, but before 45. So we need to identify whether infections or some ripple effects caused by COVID, they can contribute to lack of, let's say, depletion of ovarian reserve. So more research is required. I may also tell you that very recently we have started POI clinic, premature ovarian insufficiency clinic at the institute. This has happened very recently where we are looking at all the factors, genetic factors, immunological factors, and also other biochemical factors which can be correlated with poor ovarian reserve.
Okay, because I had a couple of podcasts before. I had it with a geneticist and a genetic lab. They do not have a specific test for detecting premature ovarian failure. I said, hey, do you have a panel that we can advise that this patient is going into POI? And they didn't have a panel.
Yeah, Dr. Asha, I would say here that unless we have very substantial data to prove that because of this genetic factor, women are experiencing POI, and that would need large scale studies. We have report, but those are isolated. So I think we need to do large scale studies to understand. We need to have more number of such kind of patients.
Ma'am, see, we are 46,000 gynecologists.
Yeah.
It's a huge number. And we have each seen at least 10 such cases in the last year.
Yeah. So I would suggest if you are seeing such kind of patient, please store their DNA or store their blood samples. And you can have good network. Probably then we can have one study where we can, I'm sure we are ready to collaborate. But we need more centers, more patients, and more clinical data, of course. So I think that is a very
So that is
important
one area where
Yeah.
clinicians can join immediately.
Immediately, exactly. That's a good suggestion.
But how? Means what would be the process? Supposing I want to join,
Yeah.
what is the process?
See, first we'll have to conceptualize, we have to write the project collectively, including all of you who are interested in this POI, the area of premature ovarian insufficiency, or let's say premature menopause. We should join hands together, and at all your respective sites, you should have capabilities to store DNA samples, to have data space, data storage. But we can make a beginning in this direction. Let's have a meeting together first. What exactly we want to do? Is it just genetics, or we want to look beyond genetics? There can be immunological factors. There can be autoimmune antibodies against ovarian cells. So we need to discuss this, I think, at length.
Yeah.
That should be the beginning. And I think all those who are like-minded or interested in this area, they're welcome to collaborate with NIRCH, or anyone can take a lead. We can work in that direction.
Okay. Now, ma'am, now we come to the next set, that small clinics, small hospitals, a gynec working, overloaded all the time. So they have OPD data. Nowadays, you definitely have to have OPD data because of the medico-legal climate. So in that case, what research do you suggest? What are the needed research that a gynec can do from our OPD data?
Yeah, it's a very important question, Nasha ji. I understand gynecologists are very busy. They may not have time to do foolproof, or let's say full-scale research program, but you are sitting on a gold mine. That is your OPD data.
Yeah.
Only I think my recommendation would be that this data should be collected comprehensively for all the parameters which you wish to investigate, or also it should be done longitudinally. So if you have this longitudinal OPD data, which is
And what is the meaning of longitudinal?
I think patients come back to you, right?
Yes.
I don't know for how many years. Again, it depends on the kind of ailment they have. But I also believe that you have good rapport with your patients, right? You can always contact them. So if you have these parameters which you wish to investigate or which you wish to analyze at multiple time points, even after the patient recovers. So if you can have that data at multiple time points, probably you can analyze this data which has been collected prospectively, and probably you can predict. For example, you can do observational studies from these OPD data. You don't have to do any further intervention. Just analyze this data, longitudinal data, for example, how patient is responding to a drug A, or let's say patient with a comorbidity, how his or her treatment response is different from those who don't have comorbidity. So that can tell you a lot about drug-drug interactions. This is one example where OPD data can be useful in predicting drug response. You can also have case reports. I mean, if you have encountered some unusual findings from your OPD data, you can publish case reports. Or cross-sectional studies can also be done, like how demographics or let's say ethnicity of patient affects the drug response. These are the various, I think, avenues which can tell you.
What is the size of the sample that is required to make the study meaningful? What is the minimum size you want?
See, if it is a case report, then one is enough.
No, not for the case report.
Yeah. See, it all depends, Asha ji, what you are asking, right? What kind of disease you are interested in. Your sample size depends on what you ask. It would vary from question to question, from research.
I have a simple question. Yeah. Many patients come to you with UTI. Some of them keep coming with UTI. You do a culture, and when the fosfomycin drug came, they were saying a single sachet is enough. That is how they are selling it, a single dose and you're cured. And I started seeing resistance to fosfomycin and I started collecting that data. That how many of my patients have fosfomycin resistance?
Okay.
So what is the sample size I require for that?
See, as I understand, UTI can be caused by different pathogens, right?
Agreed.
It's not a single microorganisms.
Yeah.
Now, to decide on the sample size, you should know the prevalence of that specific pathogen in all
E.
these.
coli, Klebsiella,
Hmm.
mostly two.
Hmm.
Very rarely Pseudomonas. These are the only three we have.
Mhm. See, I would again suggest that when it is pilot study, probably 30 should be good enough, but it depends what kind of study you have. Whether you want to prove concept of proof or you want to reach to a conclusive evidence. And my suggestion would be it's always better to consult a biostatistician rather than just assuming that this much sample size would be good enough for the kind of study you were just referring to. We always do that. There is no fixed sample size for any kind of, I would say,
So
research
for a rare
program.
disorder, maybe 30 is good enough. For something that is very common, you need more.
You need more. Yeah, exactly.
Yeah.
You need
So that
more.
means from a lay point of view, that is what I understand.
Yeah. More or less can be informed, but what exactly the sample size is, I think you need to consult biostatistician and depends on your research topic.
Okay.
Hmm.
So, many proposals come for clearance and many proposals get rejected. So what are the primary reasons why proposals are rejected?
I would say, as a reviewer, when I see different proposals which are submitted to funding, let's say to ICMR, DBT, first thing I would look for is rationale of the study. Whether the study would lead to new knowledge, new product, new intervention, or whether it would change clinical practice. So novelty is the key. If there is no novelty, if it is just me too kind of project, there is high possibility that it would get rejected. So novelty should be the key. Second is that your research methodology. It should be very sound. It should be well structured. It should be explained nicely. You may have brilliant idea, but probably reviewers won't be able to catch that unless it is jotted down properly on your paper. So it should be described very exhaustively and comprehensively. And another issue which I feel, which I've come across many a times, sometimes investigators, they try to be overambitious. You should ask specific questions and your objectives should align with the main theme of your project. Don't include too many objectives which are not aligned with your hypothesis. That is another major mistake I've seen. So we should try to avoid those kind of, don't try to do everything in one project. You should have multiple projects and ask very, very pointed and crisp questions.
Okay. So that tells a lot because it will get rejected. People don't even apply. But if they know, that these are the points that we need to take into consideration. What you're saying about getting not over ambitious is like when you open the abdomen, you can only remove what you have taken consent for.
Exactly. And I would also like to tell Asha ji, it's not that it's always a bad project that gets rejected. Sometimes good projects also get rejected because funders, they have different priority. And it's very likely the projects which got funded, probably that was a little one notch higher than what you have been proposing. So don't get disappointed. It's also possible that you may have good projects, but because of the priorities set by the funders, it may get rejected because competition is so high.
Now we come to the next question. A tier 2 city or a tier 3 city hospital, if it wants to join a multi-center study, like you were suggesting that, you can get a multi-center trial together. So what is the minimum capacity they should be having about the, supposing multiple centers are doing their study together, who takes the ethics consent?
If there are multiple centers are involved in this multi-centric study, all centers are supposed to take approval from their respective ethics committee.
Ma'am, but like I'm in Raipur, here the private setup cannot take ethical approval.
But I've heard that there are independent ethics committees which can supervise those sites which don't have their own ethics committee. So there are ethics committees which can it's done on payment basis, but they can.
Means where do we find out about them?
I think in Bombay, I'll send you some connects on that. Yeah, I'll do that. Yeah.
Because if I want to do a study, I want to be part. So how do I clear that ethics hurdle? So data capture we have. And what about the follow-up? What is that will again depend on the ethics question, right? Yeah. On the study question.
Study questions. And like when you were asking about what all these hospitals should have, for example, if I'm the coordinator, or let's assume you are the coordinator of this multi-centric study. So what I would look for that my partners in different sites, they have proven research competency. They should have good research infrastructure. And as I was mentioning...
What does that mean? What does that mean?
See, when you say research infrastructure, if your project involves some lab investigations, some test, pathology test or biochemical test, then you should have good laboratory component at your site, which is within your ambit. So you should have that facility. You should also have a facility for data storage. I was talking about ethics, probably some other regulatory agencies like some monitoring committee, data monitoring safety committees. Because that would add up. When I would look for my partner, I would see to it that my partners, they have at least some level of research competency. And also probably you should do some kind of analysis to see whether the question or patient population I am looking for, whether you have access to that patient population in terms of numbers. So that is another criteria. And we have to look for feasibility also.
So, before you apply for any research, even if you know that this can be done, you need to first audit your own facilities, whether you have the capacity, and then go ahead?
Yeah, that is absolutely essential, Ashaji. This is, I would say, feasibility analysis. Okay. Whether your place has all the components which are required for this specific project. Capability to hire people, capability to store data, and all these steps should be, I think, taken into account before you say yes to this multi-centric study.
Okay. And, supposing we get a proposal ready. We are not counting the time till the proposal. Yeah. But from the proposal to its approval and implementation, what is the timeline required? Is it months or years? What is it?
I would say minimum 1 year or minimum 9 months gestation period. When you submit to funding agency, we'll have to accept that these funding agencies, they receive projects which runs in 1,000. So they have to screen, they have to again send it to reviewer, and then they get comments. And by the time, if you are lucky, if that project gets approved, sometime they would ask you to submit approval from ethics committee. Without that, they won't release their funding. So that takes another probably couple of months. So overall, you can probably keep it at 9 months at least.
So 1 year.
Yeah, 1 year. By the time you recruit your first patient, it may be 1 year. But it's always a good idea if you have projects ready. So whenever there is a call for proposal, just submit. Okay. Sometimes they give very short deadlines. So it's very nice to have your projects ready by then.
Okay. For the young students, everybody is doing a thesis. How can that be converted into a research? How can it become a publishable paper and then a stepping stone to the future research?
This is true for what we expect for a paper. It should have novelty, it should have scientific rigor, and it should have a clinical or let's say otherwise academic relevance. These three elements are very, I would say, mandatory if you want to publish. Maybe it's little off the tangent. I can tell you what happens at our institute. We have PhD programs, but before a student submits pre-synopsis or let's say thesis, he or she should have at least 2 published papers. So we are going in reverse direction. We have papers first and then student is allowed to submit. What you are asking me is converting thesis into paper. So I don't think there is any difference. Like whatever paper we publish, those are compiled as thesis. In this case, what you are proposing, that thesis can be converted into paper, and that can be done easily if there is scientific rigor, as I was mentioning, good data, interesting data, and substantial data.
So I think the first important thing is for the, consultants who allot thesis. That, because if it is not novel, if it is just a me too, then that 2-3 years that the student is spending is gone to waste.
Yes, exactly. So onus lies on the mentor also, that they should choose good topics, relevant topics, and which are interesting to the community, I mean, scientific community.
So I come back to my original question, that what are the gaps where these mentors should be giving topics? What do we actually need to know? What we need to know, if the topics are aligned to that, there are greater chances of it being published and greater chances of going into research. When you say menopause, it's very wide.
Yeah.
Very, very wide.
See, I can give you one example since you were referring to menopause. If you can give a topic like screening or let's say identifying biomarkers for early menopause, let's continue with that discussion. I'm sure it is doable in 3 years at least, because you have access to those kinds of samples. So there is a need. There is definitely a need that we should have early biomarkers for, let's say, premature menopause or early menopause. So that is something doable, and that is something which is really needed. You may not reach to the marker, but at least you will have some data which can be a stepping stone for future programs. And I would also like to add here that a lot depends on the mentor, what he or she is interested in, and what is his or her expertise. So first thing is interest. There are multiple areas which need to be researched. But you have to make expertise in some specific domain. And I think there is the responsibility of the PI. PI shouldn't have multiple interests, because rather than doing small things in different projects, it's better to have some defined area which you can follow, which you can dive deep. So my advice would be that focus on one area and address it very comprehensively, rather than working in different areas and then just making very incremental contribution to the field.
Ma'am, is there some site where, these research topics that, we need research on this, somewhere where it's all mentioned, so that, it becomes a ready reckoner for all the mentors all over India? That they can just visit that these are the research gaps. Now let me allot my student this or that, something like that.
See, if you can follow what kind of proposals are invited. We always have calls for proposal from ICMR, DBT, and PST, DAE. They invite call for proposal, and these calls are theme oriented. And a lot of deliberation have already gone on in identifying these themes. It means these areas are really needed to be researched. So keep an eye on these areas, because they are a direct reflection of what the country needs. Although globally there have been many opportunity maps by Gates Foundation, by NIH, they have enlisted research priorities, let's say for another 5 years or 10 years. But when it comes to India, I would advise to focus on these calls for proposals.
Okay. And where are these published? on the website?
These are on websites. These are also on, like, if you can see annual reports of these organization, DBT, ICMR, they will tell you the trend which is being followed.
Okay, so
Projects
it
which are being
requires a lot
funded.
of homework.
Yeah. Without homework, I won't advise you to even think about research projects.
But ma'am, see, there are so many PGs going every year. Gynec PGs, if they can get good topics and each one does 3 years of research, we will really have so much of data in our hand at all the gaps.
But I'm sure, Ashaji, at Fogsi also you have these kind of discussion where clinical research, especially when it comes to clinical research, more needs to be done. So if your interns or let's say students, if they're attending these conferences, I'm sure they will get some clues about the areas which need further research. Although it's very possible that some of these areas may not have national relevance. They may have limited scope. But I think these conferences are another platform which can tell us what needs to be done further.
Okay. So ma'am, could you tell me about some project at NIRCH which actually the research was done and then it was implemented on the bedside? It had clinical relevance.
Yeah, it's not very recent, but I personally feel that this project made a lot of contribution to the field. This was during the pandemic. That's why I attached a lot of importance to this project because it was done during difficult times. This project this project was undertaken to assess the impact of COVID-19 on pregnancy outcome. So our scientist, especially Dr. Rahul Gajbee, you know him. So
Yeah.
he established this pre-COVID registry. And this registry was established in association with the Nair Medical College, Nair Hospital, and also with Maharashtra State. And this was done in Maharashtra across 19 medical colleges. The whole idea was to see whether COVID-19 impact pregnancy outcome and also postpartum effects. So this data clearly showed that women who have pregnant women who have COVID-19, they have a lot of adverse pregnancy outcome, low birth weight, preterm deliveries. And this evidence was the premise on the basis of which government took a decision to vaccinate pregnant
women.
So this was a good achievement from our side. This is not directly from lab, bench to bedside.
But it is basically research tied with outcome.
Yeah, exactly.
It got implemented and it benefited a lot of women because in that COVID, I lost 2 of my pregnant patients. You really can't do anything. They were just sinking and they were on ventilator and gone.
Yeah. So vaccination was savior for, I think, for all of us.
Yes. Yeah. Now, ma'am, there are cross-disciplinary researches also, along with AI, with microbiome, mental health, environmental exposure. So how do you tie up for these cross researches?
See, we all agree that these health problems are complex and they need multidisciplinary expertise. I can also cite example at our institute. We have a good mix of basic scientists, clinician, and public health experts. Yet, if we need something, for example, we are making 2 devices. One is placenta on chip, where we are trying to create placenta-like environment on chip. And also, we are creating a model for sorting good quality sperm. But we realize that we don't have expertise in-house. We don't have expertise in biomedical engineering. So we approach IIT Mumbai. So in collaboration with IIT Mumbai, because they have the expertise, we are making these devices. So cross-disciplinary expertise or cross-disciplinary projects are very, very important if we want to, as you were saying, from bench to bedside. So these kind of multidisciplinary projects are important. And if you want to identify, I think people who really want to contribute or do good science, they're approachable. You can approach any of them at any of the organization, because everyone has realized that a time has gone when everyone was working in silos. If we really want to make a dent, we need to have this cross-disciplinary approach.
Okay. So everything comes down to your homework. What is your research question? And then you look for the collaborators. Is there any place where these kind of projects are already listed where you can join in?
I think institutional websites are the good platform where almost all projects are listed. It depends, like if in your vicinity you have some good public funded organization or some other organization, you can just approach their website.
Okay. So like anemia in pregnancy, we started with that. What are the research questions we have regarding anemia? Is it the screening frequency? How often should we screen? Should we give IV or oral iron? Or, postpartum, should we again screen the patient? What are the research questions needed for anemia?
Yeah, when it comes to anemia, especially in pregnant women, I think we still haven't reached there, although WHO in 2024, they have released these revised guidelines in terms of diagnostic threshold for diagnosis of anemia across different trimester. But these guidelines are not adjusted for ethnicity. I'm sure you know that Black population, they have lower level of hemoglobin as compared to white population, irrespective of the fact, health status, nutrition, everything is taken care. Still, they have low hemoglobin. So ethnicity can be a major contributory factor when it comes to, but these guidelines, they need to be adjusted for this ethnicity issues. So that is one area. Another area is, I'm sure is known, is well established, that anemia is a progressive disease. We detect it when it's already established. If we can identify early biomarkers in terms of iron depletion, because I think iron deficiency anemia starts with depletion of iron. If you can have good biomarker for which can tell us that iron is getting depleted, although a lot of work is being done in case of ferritin, hepcidin, and I think also transferrin receptor, truncated transferrin receptor protein. But we are still not there. Like there is no single test which can tell me that yes, I have depleted resources for iron. So we need a biomarker and when it comes to treatment, as you were saying, a lot has been done in case of oral, intravenous, different kinds of ferrous carboxy maltose. Now people are also talking about erythropoietin for addressing anemia. So, but all these are in formative stages. We need to do more research. We need to identify new treatment modality for anemia, especially in case of severe anemia.
Your CV tells me that, endometriosis and adenomyosis are your forte. So,
endometriosis.
Endometriosis. So in endometriosis, what is the research that can change the outlook of the disease in the next 3 years?
In terms of research, I think the field still is searching for non-invasive biomarker for endometriosis. That is one. If we can identify early biomarker, we can significantly reduce this diagnostic delay, which is associated with endometriosis. And this diagnostic delay is one of the reasons when women approaches a clinician, the disease has already, I think, reached to higher proportions. So early biomarkers, non-invasive biomarkers would be very, very helpful. Another area can be if we can develop non-hormonal treatment for endometriosis.
And there's another thing, chronic pelvic pain.
Yeah.
It's debilitating. It may not be because of endometriosis.
Yeah. So if we can identify a marker which can tell me that this chronic pelvic pain is not because of endometriosis, some kind of discriminatory biomarker would be of great help to, I think, our young girls and women.
So are we anywhere near it?
I don't think so. We really need to do more research on that.
Okay. And in infertility, ma'am, we've spoken a lot about menopause, but what about infertility? What research is needed in the field of infertility? Because if you see, so much work is being done in infertility. So something that would reduce the cost and make infertility treatment more approachable for the normal person.
I think what's major achievement I would say has been done in the area of infertility is in the area of assisted reproductive technology. A lot of inroads have been made there, but when it comes to infertility, which may not need ART, I think we need to gather a lot of data. Right now, we don't have prevalence data for infertility across India. I may also share with you that recently, not very recently, couple of years back, we received a call from Sikkim Health Secretary. They are extremely worried about low TFR in Sikkim. There, I think TFR is 1.2. But when we went there, we realized that it's not truly infertility, it's elective childlessness. The women, they don't want to opt for
More children.
Family doesn't want to opt for. They want to postpone their parenthood. The reason could be any, but we have to really demarcate infertility and elective childlessness.
Tough.
So I'm sure it's very, very tough. And another point is, do we have fertility services at PSC level? Do we have data? How many couples are really infertile? Because these services are, majority of the time, those are available at tertiary hospital, not at PSC level, barring some simple test. So we really need to strengthen our infrastructure for when it comes to infertility services. And talking about reducing expenditure, I think we need to invest more in products which are made in India. Many of the products are still imported, which are used in ART. If we can make products which are indigenous, I'm sure this will help in reducing cost, which is associated with the IVF.
Now, ma'am, when two people do business together, the deal breaker is the money. Similarly, when a paper is being authored, and now supposing it is a multi-centered trial and it's being done, what is your advice on authorship, data sharing, and IP when multiple centers collaborate so that friendships will survive the paper?
My strongest advice would be, before you start study or before you put this on paper, please enter into a MOU with all your partners, which should define role of each investigator, authorship issues, and also ownership issues. Who would be the owner? Normally, authorship, we have very well-defined guidelines. ICMR also has guidelines on these aspects.
Okay.
And also, I think ICNJE criteria is there to define who deserves authorship. And if there are multiple investigators, you can club these multiple investigators as a group author. Everyone can be clubbed.
Okay.
If you have too many, which probably cannot be accommodated, so you can give them their due credit as a group authorship. That is one provision.
In India, you gave us one example of, the work you did during COVID and how it led to vaccination. So what kind of evidence do you need so that it gets pushed into national guidelines? Because we have so much of evidence that screening for cervical cancer helps.
Yeah.
It is still not there in the policy guidelines.
See,
so what evidence do you need so that it can just be directed that way?
See, highest level of evidence which can be directly incorporated into, let's say, guidelines is systematic reviews and meta-analysis. I may also share with you that now Department of Health Research, Government of India, they have established a Center for Evidence-Based Guidelines.
Okay.
So these guidelines are framed in consultation with experts, domain experts. but they also do this systematic review of systematic reviews, meta-analysis. So highest level of evidence is needed if we want to frame guidelines. Another point I would also like to add here is the shortest route probably is through cost-effective analysis. Our institute has Health Technology Assessment Resource Hub. This is called HTA, where they do cost effectiveness of new product, processes, interventions. So that analysis part is immediately taken up by the ministry. I can cite one example here. I'm sure you are aware about the sickle cell anemia elimination program. So government asked us to assess cost effectiveness of 2 point of care tests. One was sickle scan, another was hemotype. So we did some cost effectiveness to see whether these 2 point of care devices can be introduced into national program at a reasonable rates. So this cost effective analysis data was given to the ministry, and ministry immediately they wrote to principal secretary of almost 17 states, and they made this decision that these two POC can be used for screening of all those who have screening for sickle cell disease or trait in those endemic areas where this disease is prevalent. So this is again from bench to bedside example.
Thank you, ma'am. Now I want to ask you, supposing you had funds and there were 10 projects, small projects that you could fund, what would be the topics?
I would 10 topics you are asking me, or there can be multiple projects in one area. So my first priority would be identifying bone markers for bone loss, which will help in menopause, screening of menopause, or let's say premature menopause. Second would be treatment modality for PCOS. Polycystic ovarian syndrome is another big issue. Young girls, like sizable number of young girls and women, they are affected with PCOS, but we need non-hormonal treatment strategies for them. So that would be second. Same goes for endometriosis. Again, for endometriosis, we should develop non-hormonal therapies for treatment. Another can be, we should look for determinants of vaginal health. This is another issue. RTI, STI, almost, I think, 50 to 60% of women, they experience this episode at least once in a lifetime. So vaginal health, again, is very, very important, and we should know what microbial composition contributes to good vaginal health.
But this is very expensive, ma'am. Getting the vaginal microbiome tested is 15,000 rupees for one patient.
Yeah, right now it is, but all this data, Dr. Asha, is very important if you want to develop a good vaginal probiotic. And then probably in the future, we will have more targeted approaches to detect vaginal dysbiosis. So that is one. And when it comes to social factor, I think we cannot just focus on biomedical research. We also need to promote health-seeking behavior in women. What prevents women from seeking care? So we should look into social. We should look, and we should create awareness about health, especially among young girls. And I would say, if we invest more in preventive, promotive, and predictive solutions which women can use in real time, self-monitoring, those kind of solutions, let's say for screening bone health, vaginal health, menstrual health, if we can have those solutions, I'm sure this will make lives of our young girls and women very easy. Prevention, we always say, is better than cure. So more investment probably should be done when it comes to preventive health solutions. You are muted. Madam, you are muted.
So we've done 6, ma'am, and now we are nearing the end of our podcast. I'm giving you very short rapid fire questions. So we end with that. is there a myth about clinical trials that you want to bust?
Yes. Not all clinical trials are risky. I think it's a myth that clinical trials are risky. I would say not all clinical trials are risky. You can also have observational clinical trials.
Okay. So, is there a data set that India already has that we are underusing?
ICMR has developed this health data repository, which has data on PCOS, antimicrobial resistance, and other risk factors for diabetes. I think those data sets should be used to its fullest. Although these are not very old data sets, I mean, this repository has been recently created by ICMR DHR. So those data sets should be accessed.
One research habit that you want all of us to adopt from today or tomorrow?
I'm sure you already do it, but I would still suggest that read at least one paper every day in very high impact journals and focus on methodology. That would be of really great help when you are writing your projects.
One area where AI actually helps and one area where it doesn't.
Where it really helps is, I think, diagnostic. I'm sure you all are aware about this, how AI is helping in diabetic retinopathy. And where it doesn't, I would again say diagnostics. Diagnostic for rare diseases, because they don't have data, so there is no specific AI-based tools for those.
And if there is a dream multicentric study which you would wish all of India to adopt.
Yeah.
A dream. It doesn't have to be, specific, but a dream that you have.
If I'm given enough money, enough manpower, and a lot of collaboration if I have, I would like to start with a longitudinal cohort of school-going girls, and I would follow them up at least until their first pregnancy. I'm sure this data would give me a lot of insights about the biomarkers for various pathologies, be it PCOS, be it endometriosis, be it fibroid, or be it, risk factors which predispose women to pregnancy complications. So a big cohort of longitudinals. Right now, what we are doing is we are doing cross-sectional studies where disease has already developed. We need to catch them early. All kinds of women's health diseases. We need to catch them early and develop them into solutions. So that would be very, very ambitious, very expensive, and I'm sure very time intensive.
And your dream.
Yeah, that would be, I think, worth doing. Not easy, but worth doing.
So, ma'am, we are at the end of our podcast. Thank you very much. Just one take-home point which we can all take with us today before we end the session.
Asha ji, I would say that we are living in a good time. Everyone is now focusing on women's health. And there is recognition of the fact that women's health is important not only for their family, but for the whole nation. We are 50% of the whole population, global population or national population. Our health is very, very important if we want to contribute or if nation wants to grow further. So that is that we should take care of our mother, our sisters, all women in our family. We should take care of their health. And as researcher, we should focus more on the areas which haven't received their due attention so far. That's all from my side.
Thank you, ma'am. For me, what you said, prevent the preventable. That was very, very important. And you added all relations except yourself. We need to look after our own health as well.
Sure.
So thank you so much, ma'am, for being on this Fogsi podcast. I'm really grateful to Sunita, ma'am, for giving us the opportunity for interacting with such big people like you, who can actually guide us how to go about future into the research and do what our country needs. So thank you so much.
Yeah, it was pleasure talking to you, Asha ji. Thank you, and thanks to Fogsi.
Thank you.